Hi, I'm Dr. Shivbala. Uh, Today I will be discussing about evidence-based medicine. I will be discussing an imaginary case scenario, and that case scenario, based on that, I will guide you how to use the evidence which is present to tailor the therapy for that patient. Today basically we are going to see how to apply the evidence which is present to guide the therapy for the patient. I'll be discussing an imaginary case scenario, and basically, so for example, this will be useful for you in many instances. So how to approach an article, how to read, go through an article, and how to apply it to that particular patient for management. Since evidence-based medicine is the current trend, which has been going on for a long time, basically. We have a patient who is having peripheral artery disease, and he's asking you how to improve his physical function and walking. So the thing is, we will make an imaginary scenario like this. So you are a general internist. So you are following up a 62-year-old man, and he is having a history of type 2 diabetes, mellitus, hypertension, and hyperlipidemia. He is on oral hypoglycemics, statin, and thiazide like diuretic. So a vascular surgeon recently evaluated that particular patient and for intermittent claudication, and he made the diagnosis of a peripheral artery disease. So a surgeon again prescribed a low dose aspirin and pentoxifylline to reduce the patient's risk of vascular events and improve his ability to walk, citing two systematic reviews. One systematic review, a review of antiplatelet agents in peripheral artery disease that found a decrease in the odds of vascular events, an odds ratio of 0.78 with a 95% confidence interval, and another review confidence interval being 37 to 81, and the other review of pentoxifylline in peripheral artery disease, which increased maximum walking distance by 59 meters. The 95% confidence interval being between 37 and 81 meters. So, despite the new treatments, the patient is unable to walk more than 2 minutes without pain and finds his quality of life substantially being impaired. So, listening to the patient's history of poor response to treatment and ongoing symptoms, you see that patient and how to evaluate the patient. So by during the time you recall and seeing an article which may be relevant. So you ask him to return in a week for further review of his medications. So how to find the evidence? So for this particular patient, how are you going to formulate a structured, an anatomical way of approach? So first, you formulate the relevant question for this individual. In a patient with a debilitating peripheral artery disease, treated with antiplatelet therapy and not a candidate for surgery, how can we improve symptom-free walking? So to conduct a rapid search focused on the most recent pre-appraised research, so we opt for ACP Journal Club. So that is something which is a separate journal club which you can find it online. So ACP Journal Club dot acponline.org. So we type the terms peripheral vascular disease and intermittent claudication. This is Boolean and this is Boolean. So we identify 7 pre-appraised editorial summaries of studies, one of which turns out to be a target. Okay, so that study goes on like this. The Ramipil improved walking times and quality of life in peripheral artery disease and intermittent claudication. So we print a copy of the summary and the original full text article that reports the results of the trial, effect of Ramipil on walking times and quality of life among patients with peripheral artery disease and intermittent claudication. So that particular article includes 212 patients with peripheral artery disease with a history of stable intermittent claudication. These participants in that study, they were randomly allocated to Ramipral 10 mg daily or placebo for 24 weeks. So for that study, the primary outcome was pain-free walking time and also maximum walking time at one stretch. So how to approach this article? So we have to divide this article the analysis of that article into three parts. So first we have to see how serious was the risk of bias. Second, we have to see what are the results. Third, we have to see how can you apply the results to patient care. So in that study, how serious was the risk of bias? So first, we are going to discuss how serious. So basically, the three parts as I told before: how serious was the risk of bias, what were the results, and how can I apply the results to patient care. So these are the three major divisions by which you analyze an article. So whatever articles you read or come across a journal club, so what exactly are you doing? So basically those must be translated to clinical care. Secondary objective for you should be to analyze that article, how they conducted the study, so that you can replicate, or sometimes you can find you can add on to the existing evidence by doing something new, by creating new studies. So that will be the two objectives for you to read an article. Okay, so the coming to the primary outcome of your primary objective of your uh, understanding to understand an article will be to guide patient therapy, right? So first you should find out what were the biases in that study. Second will be the results of the study, and third will be how to apply that results to the patient care. So we will dissect each and every division, these three divisions, step by step, and we will see how that can be done. So first question, first broad division will be how serious is the risk of bias. So under that there are multiple questions you should keep in mind. So the first question should be, did the intervention and the control group start with the same prognosis? So when patients randomized. So so how to say go for this? How to go about this is, so consider the question of whether hospital care prolongs life. A study actually has found that more sick people die in hospital rather than in the community. So we would easily reject the naive conclusion that hospital care kills people, because we recognize that hospitalized patients are sicker than patients in the community. Although the logic of prognostic balance is vividly clear in comparing hospitalized patients with those in the community, it may be less obvious in other contexts. Say, for example, many people believe that a diet rich in omega-3 fatty acids will decrease the risk of cardiovascular event. So, how did this belief arise? So, this belief arose from many observational studies in which people who ingested larger quantities of omega-3 fatty acids had fewer cardiac events than those who had lesser quantities of omega-3 fatty acids. However, large randomized trials did not find any benefit of omega-3 fatty acid supplementation. So other surprises which are generated by randomized trials include a demonstration that antioxidant vitamins fail to reduce gastrointestinal cancer. One such agent, vitamin E, may actually it may increase the all-cause mortality, and that a variety of initially promising drugs increase the mortality in patients with heart failure. Such surprises occur periodically when investigators conduct randomized trials to test the observations from these studies. So whatever observational studies we see come across, eventually they sometimes eventually they are proved to be wrong by through randomized trials and done in a timely basis, in which the patients and physicians determine which treatment the patient receives. So the reason that studies in which a patient or a physician preference determines whether a patient receives treatment or control often yield misleading results. So basically, the treatment studies attempt to determine the impact of an intervention on events such as stroke or myocardial infarction and death. So these three occurrences, we call it as the trial's target outcomes. The patient's age, the underlying severity of illness, the presence of comorbidity, a host of other factors typically determine the frequency with which the trial's target outcome occurs. These are called the prognostic factors or the determinants of outcome. If prognostic factors, either those we know about those or those we do not know about, prove unbalanced between trials, treatment, control groups, then the study's outcome will be biased. So now we understood that how and when a study's outcome can become biased. So but whereas the observational studies can theoretically they can match patients either in the selection of patients or the study or the subsequent statistical analysis for known prognostic factors. So for our, but not all prognostic factors are easily measured or characterized. and in many diseases only few are known. Therefore, even the most careful patient selection and statistical methods are unable to completely address the bias in the estimated treatment effect. So the power of randomization is that the treatment and the control groups are likely to have a balanced distribution of known and unknown prognostic factors. That is the significance of randomization. So as I told before, for example, consider the example of our omega-3 fatty acid studies. So what was the cause of bias in the omega-3 fatty acid study, observation studies? People who eat larger amounts of omega-3 fatty acids may typically have a higher socioeconomic status rather than those who eat smaller amounts, naturally. So in addition, people who eat larger amounts of omega-3 fatty acids may eat fewer unhealthy foods and may be more careful with the other important factors, because they know that they're in a study, and they are in a better position to avoid the important risk factors, for example smoking, and to undergo the precautionary measures such as the exercise. So their apparent benefit from omega-3 fatty acids may reflect their healthier lifestyle. Whatever the explanation, we are now confident that it was their previous prognosis rather than the omega-3 fatty acids that lead to lower risk of cardiac events. So we understand where the bias is there in observation study. Although randomization is a powerful technique, it does not always succeed in creating groups with similar prognosis. So investigators may make mistakes that compromise randomization, or randomization may fail because of chance. Unlikely even sometimes can happen. So how does all these things happen? So the thing is, when enrolling such patients, sometimes people are unaware and cannot control the arm to which the patient are allocated. uh, we refer to randomization as concealed. In unconcealed trials, those responsible for recruitment may systematically enroll sicker or less sick patients to either treatment or control group. So this behavior will compromise the purpose of randomization, and the study will yield a biased result. So careful investigators will ensure that randomization is concealed through strategies such as remote randomization. What is remote randomization? So the individual recruiting the patient makes a call to a methods center to discover the arm of the study to which the patient is assigned. So for example, um, consider for instance, for example, a trial of beta blockers versus AC inhibitors for hypertension treatment that used opaque numbered envelopes to conceal randomization. At the time of study was conducted, the evidence suggested beta blockers were better for patients with heart disease. Significantly more patients with heart disease were assigned to receive beta blockers. In addition, evidence suggested that AC inhibitors were better for patients with diabetes. Significantly more diabetes patients were assigned to receive AC inhibitors. It is possible that clinicians were opening envelopes and violating the randomization to ensure patients received what the clinicians believed was the best treatment. Thus, the prognostic balance that randomization could have achieved was prevented. Were patients in the treatment and control group similar with respect to known prognostic factors? That will be the second question under the broader division. So the purpose of randomization is to create groups whose prognosis with respect to target outcomes is similar. Sometimes, through bad luck, randomization will fail to achieve this goal. The smaller the sample size, the more likely the trial will have prognostic imbalance. That is why usually we give a larger sample size. So, for example, picture a trial testing a new treatment of heart failure that is enrolling patients classified as NIHA class 3 and 4 heart failure. Patients with the class 4 heart failure have a much worse prognosis than only class 3 heart failure. The trial is small with only 8 patients. One would not surprise that all 4 patients of the class 3 were allocated to the treatment group and all 4 class 4 was allocated to the control group. Such a result of the allocation process will seriously bias the study in favor of the treatment group. So where the trial to enroll 800 patients, one would be started if randomization placed all 400 patients class 3 heart failure in the treatment arm. The larger the sample size, the more likely the randomization will achieve its goal of prognostic balance. Okay, so the second part will be continued in the next video.